So 37-year-old male brought in by EMS after getting hit by a bus while waiting at the bus stop. EMS intubated patient in the field, obtained IV access, initiated ketamine drip. Respiratory therapist at bedside ventilator with a ventilator upon arrival at the ED, which initial ventilator setting is most commonly used in the ED after intubation.
Delta?
Yeah, D, right. And probably the most commonly used out of all. Perfect. Let's keep going here. So you got a marathon runner, stops at the medical tent, halfway mark. Complaining of headache, dizziness, leg cramps, no abnormalities in the neuro exam, vital signs 110/70, heart rate 115, respiratory 20, 10.1. SpO2 is 98% of room air. What is the most appropriate immediate treatment for this patient? I think I heard E.
Echo?
Yeah. So this patient, he doesn't have heat stroke type symptoms, TEMS 101, no neurologic abnormalities or normal mental status. Yeah, and I've still never seen a cold water rectal lavage, but I'd like to. I'm scared to Google it. All right, got a 26-year-old Marine suffered injuries following ID blast presents from a remote aid station in Afghanistan, multiple small blast wounds, lower extremities, lower abdomen. After following the March treatment priorities and stabilizing the patient with whole blood transfusion, which antibiotics should be administered for this patient? D. I think I heard you say, yeah, ertapenem. Good. All right, let's move into head trauma today. So we're going to continue on, talk about head trauma, the usual pathophys, epidemiology, what we're going to do for it. And we'll start with our warm-up case. So 45-year-old unbelted male driver involved in a front-end motor vehicle collision, found disoriented, not responsive to commands. Initial GCS was 11. However, he deteriorated during transport, arrived with a GCS score of 10. Vitals otherwise stable, no apparent trauma outside the deformity of the left upper arm. Initial exam was significant for contusion on the scalp. Well, as palpable depression along the right temporal region, pupils both equal response bilaterally, and then fast exam was negative. So here's our priorities. So even with a head trauma patient, like the key takeaway is there are trauma patients. We treat all trauma patients the same. That's why I think trauma is kind of boring, because it's like cookie cutter protocolized medicine, so it's not as fun sometimes. But I mean, it is nice that you can follow an algorithm and come to a conclusion. So the big thing, if there's any significant bleeding, we need to stop it. And then, does he have an airway? How's it breathing? Do I need to put a tube somewhere, whether it's, an endotracheal tube versus a chest tube? Do I need to fill the tank back up? Do I need any blood? And then really look at their GCS. We can do precautions, which we'll talk about today, but a lot of head injury precautions or brain injury we use are just elevating the head of the bed initially, trying to prevent any or trying to decrease that intracranial pressure if it's elevated. And then we do the rest. We expose, treat for hypothermia, get our EFAS, and then hopefully we can go to CT. If not, they need to go to the operating room. All right. So, we classify TBI into different categories based on their GCS scores. The most commonly used one. So we got mild, moderate, and severe. And you'll see some variation in scoring. Some think because there's a big jump between 13 and 14 on the GCS. So some say mild is 14 to 15, some say 13 to 15, but we're going to go with 13 to 15 on this. But most head injuries are going to be in that mild category, or over 80%. What we're concerned with are those like moderate and severe traumatic brain injuries. So they account for less, but a decent percentage will require some sort of neurosurgical intervention, and they do carry a pretty high mortality. Most of what we do for these is we try to prevent any secondary injury, and then we try to get them to neurosurgery is kind of the treatment we perform mostly in the ED. It's important to remember that the brain and the skull is obviously a fixed volume. So when we have an increase in anything in the brain, it can affect that cerebral perfusion pressure. So if ICP increases, something else decreases, and then it creates that constant pressure in there. And that's really what we're trying to manage for most of these traumatic brain injury patients. Normally, like, our auto-regulation adjusts everything for us, but when we have some sort of insult to that area, that's when we can start changing those parameters like our CPP, MAP, and ICP are the big ones that we're looking at. And there's how we calculate it. So cerebral perfusion pressure is MAP minus ICP. So any injury is going to affect that, and our biggest concern is going to be keeping that MAP in the appropriate level and then monitoring their ICP, which we can't do unless we have some sort of inline monitor. So we kind of estimate based on their blood pressure and their MAP what we think that ICP is and physical exam. The issue is any of those secondary insults that we're trying to prevent, like hypertension, hypoxia, those increase significantly their mortality rate, which is why we manage these pretty aggressively. So, any sort of hypotension is going to cause ischemia on that brain, so we're going to, make sure we keep that MAP over 80 or their blood pressure over 110 is our goal for these patients. And then we need to, factor in whether we think they have some sort of increase in the cranial pressure, which we can look at on, if they're still conscious. That can be helpful for us to do some sort of neural exam, or we can look at like pupils and our different brain herniation syndromes, which we're going to talk about. All right, so here's our primary injuries. We have contusions, hematomas, so like our subdurals, epidurals. We have like our hemorrhages, our subarachnoids. And then we have diffuse axonal injury, and then other injuries that we don't really classify on here. But what the importance of what we're doing is create, we can't prevent that primary brain injury because it's already happened. So we're worried about any secondary brain injury and trying to prevent it. So to make sure we're managing that, we like to say normo or U everything. So we want, normal tension. I don't know if normoxia is a word, but we're going to say it. And then we want to prevent any like hyperglycemia, anything that can increase that ICP so we can avoid those worsening outcomes in these patients. Here's like a graphic of the different types of herniations that we see, and we'll go into it a little more in depth on what some of those symptoms are. But there are classic ones, especially when we're talking about like board questions and things like that. We have like our uncle herniations are commonly asked on questions, and they're easy to tease out based on our physical exam findings. Then we have, our most common is going to be like a midline shift, which we'll talk about. But here are the different ones we're going to cover today, like our subfalcine uncle are kind of going to be the two more common ones that we see. And just based on where that insult or injury is, it has a particular pattern when we look at herniation. So is it pressing down through the brain stem? Do we have like some sort of disruption of the skull where it's pressing out there? So we'll kind of talk about it a little more, but this is, one that is, we have certain findings on our uncle herniation. It's not the most common, but we do see it. We do see a lot of epidural hematomas, and this is what we can see it with. So you have some sort of injury or displacement of that temporal lobe, and it kind of presses down there on the medial edge of the tentorium. So then you get those fixed and dilated pupil on the side of that lesion. And then for the herniation, you start to see opposite side motor paralysis in these patients. And then it can lead to like decerebrate posturing. And then we have our subfalcine, which is the most common, and this is going to be our midline shift. So, does everybody agree that doesn't look like the normal area in the brain? So we have a large shift occurring there. And this can be from multiple different types of lesions, but some sort of mass effect pushes it in medial direction, and then we can get contralateral leg weakness. I can't talk. And then we have our cerebellotonsillar herniation. So this one's gonna, push down onto those cerebellar tonsils, and then it can create like pinpoint pupils, flaccid paralysis. This one's usually pretty bad, sudden death. Upward transentorial, you can get that conjugate downward gaze with it. So, it's important to differentiate them, especially when you're taking tests. And, in the real world, with any sign herniation, we start doing the same treatment for it, which is really we need a neurosurgeon. We need to evacuate or reduce that pressure somehow, which we'll talk about some of the methods we can use emergently in the trauma room. then here's our GCS. So I mean, I feel like you guys are good with GCS, right? You've been on like 5 tests, so, or maybe 3 tests this semester. So we have our eye, verbal, motor, and then we categorize it, mild, moderate, and severe. And what's important to remember with GCS, we like to get that initial GCS so we can trend it. So we want to see what it was, hopefully, and an important thing to remember is like in the EMS GCS as well. So EMS, when they give you their report for the trauma patients, you want to get what their initial GCS was if they were able to get one. And then we kind of trend it when they come to the ER, what's their GCS once they're here, and then depending on what sort of findings we have, we may repeat it every 5 minutes if we're worried about like herniation and things like that. All right, there's our normal head CT. So you can see like there's no midline shift. You don't see any sort of like hematoma in there. This is not a great the contrast. There's basically different. You can look at like a bone window. So that's what the word I look for. This isn't the right window to look at like bone and skull fracture. So there's another. You can adjust the settings and look at different windows. So it's hard to tell if there's skull fracture there or not. But there isn't. Obviously, it's a normal one. But here's our abnormal finding. So does everybody remember how our epidural looks? It looks like that, like kind of lens-shaped area of hyperdensity in there, and then we have, our subdural, which looks like that kind of moon-shaped density, and then we have our different contusions, hematomas, diffuse axonal injury, just kind of looks kind of grayed out and a loss of that like gray and white matter in there. And then we have our subarachnoid. All right. So like I said, we want to get that initial GCS. It does have quite a bit of evidence behind it. It is still kind of basic overall, but it is the most research tool that we have. So we want to assess that initially when they present. If we can get that accurate history, that's very important. So once again, if EMS has GCS, and then we want to know what the mechanism of injury is. Things that we like to consider for trauma, like if it's motor vehicle accident, were they wearing a seat belt? If they were on a motorcycle, were they wearing a helmet when this accident happened? Was there any ejection? Any fatalities at the scene? These are common things we want to know. And EMS will usually tell us that during their EMS handoff when they come in. Medical history is important, especially anticoagulants. That's something we want to know. And we all want to think trauma's like super sexy and all this cool stuff. Everybody's getting shot, stabbed, and all these motor vehicle accidents. But like 50% of the time, it's an old person who fell. An elderly patient, they fell, they hit their head, they're on anticoagulants. I think that's about half the trauma patients we see on a normal day. So it's important whether, that we know whether they're on any sort of anticoagulants or anything that's going to increase their bleeding risk. And then because we're getting that GCS, we're trying to get neuro exams. We want to know if they're on any drugs or intoxicated, or if, the reason they're altered is because it's from the head injury versus they were, intoxicated, using some kind of drug, or had some toxidrome. All right. So our physical exam, first we stabilize, kind of what we talked about at the beginning. So we go through our ATLS protocols, we do our primary survey, and we want to fix anything else that can cause these symptoms during trauma. So we want to make sure we got enough blood in there if they're bleeding from somewhere. We want to make sure they have, a chest tube if they need it. A lot of times if there's enough, because motor vehicle accidents are usually the most common, so we want to make sure that there's no other concomitant injuries that can cause these symptoms while we're evaluating them. And like it says, we like to get a pre-intubation GCS if we can. Sometimes we're not able to, but that can help kind of like stage what we think they're like, or it'll help us decide whether we think that this GCS is declining after we intubate. It's very difficult once we intubate to get a good neuro evaluation. So we try to use short-acting agents if we can to bring them out of that paralysis or anesthesia, so the neuro can get a good exam on them. But we want to check the pupillary response, so the equal round reactive. I think normal pupils like 3 millimeters. Some patients can have like the mesochoria, which is going to be, usually not a large difference of their pupils, but it's large enough to be noticeable. They say it's on like 30% of the patients. Like 30% of the population has two different pupil sizes, and I feel like I would notice that in 1/3 of my patients, but somehow I don't. But I do think about it because I'm like, is it really that high? I don't know how they're measuring them. Maybe they're a lot better measuring them than me. But we want to look for like any single fixed dilated pupils. This may be an indication that they're having some sort of herniation syndrome, or it can help kind of guide us on where we think that hematoma might be located. And this is where it can be a little bit difficult when that patient comes, because we want to figure out what their motor function is, and it's very basic with our GCS. Really, even our neuro exam initially during the primary survey, during the trauma assessment, is like, are they moving all 4 extremities? Is sometimes all we're looking at. If we're, once we stabilize them, moving our secondary survey, that's when we get a little bit better neurologic exam on these patients if we're suspecting some sort of traumatic brain injury. There's our decorticate and decerebrate posturing. There we go. All right, so what's important is we need to determine initially whether we think that this patient's going to need a CT scan of the brain. For most trauma patients, if they meet a level 1 criteria, they're going to get a CT look at the brain, and really a pan scan for most of them with the right mechanism of injury. But the CT is sensitive for any sort of hemorrhage or lesions in there initially. So that's what we're looking for. There are some times, we may consider not CT in the brain, especially if they've got a good GCS, there's no mechanism, doesn't look like they have a head injury. Times we consider always scanning is anything, like especially elderly patients over 65, we have a lot lower threshold for scanning, so we're likely going to CT their head and their C-spine, just because they're elderly. We worry about easily fractured areas in that C-spine, osteoporosis, things like that. So we have a lower threshold for imaging in the elderly, but it's something we need to consider when we're evaluating them. C-spine, we're going to talk about that in the next lecture for our neck trauma. But we want to also evaluate for C-spine injury. Most of the patients that meet the trauma criteria are going to come in with a seat collar on them. But it is something that can be easily missed. So most of the time we're not just going to get a brain CT, we're also going to get a C-spine if it's a trauma patient. But especially if they're altered in any way, they have the right mechanism or any sort of neurologic deficit. And we'll talk about some of the criteria we can use for CT scan rules for this cervical spine in the next lecture. All right, so pre-hospital, they're going to stabilize these patients at the scene, and then they're going to evac to somewhere with neurosurgical capability, which is usually a level 1 trauma center. So anybody they suspect a brain injury, they know the protocols too, so really aggressive airway and blood pressure management is what we're trying to accomplish here. So we want to avoid any hypoxia or hypotension in these patients. During transport, we don't do, I don't know how long ago they used to do, like prophylactic hyperventilation. I guess it used to be a thing like long before I was practicing. For hyperventilation in herniation patients, there still may be some evidence for it. Usually they're transferred or sent to a level 1 with neurosurgical capabilities. A lot of times we don't do it anymore, but there's no prophylactic hyperventilation. All right, so here's our primary goals. We want to prevent any secondary brain injury in these patients, so we want to make sure that they've got, blood pressure over 110 or MAP around 80. And then we want to correct any hypoxia, so we have a lower threshold for securing an airway in these patients. And we also need to, identify any of those concomitant injuries, like attaining the chest tube as well. We like to keep them euglycemic or normal of everything. And then we consult neurosurgery, emergently in patients with significant GCS score or anybody we suspect with a bleed or moderate to severe. So there's, so you got pretty significant increase in mortality for even like a very short drop in their blood pressure or their oxygen level. So you're looking, at pretty significant increase in that mortality, which is why we aggressively manage all of their vital signs and keep them in that normal range. And then we want to observe and look for any signs of that herniation or elevated ICV. So if they were mentating beforehand, we want to check for any changes in mental status, pupillary changes, neurodeficits, and posturing is never a good sign. So, we kind of already beat the dead horse on aggressively managing all of those other derangements to prevent that secondary injury, but it's something we start in the pre-hospital phase because his TBI is progressive. So there are a lot of joint goals and goal-directed protocols when we're talking about dealing with TBI and the ED, trauma, and neurosurgery. So, once again, when we initially stabilize, we need to evaluate for anything that we think may cause any airway compromise. So if they're altered, we're going to secure their airway. If we have that facial and neck trauma, we're going to look at performing some sort of intervention if we suspect that they're going to lose their airway. We need to treat any pneumothoraxes they have. And like I said earlier, use a short induction agent so we can back it off later so they can get a good neuro exam. All right, so we're trying to prevent that ischemia in those low flow areas. It can worsen that neurotoxic cascade, increase cerebral edema, which is why we aggressively manage that blood pressure. Normally, like I said, MAP 80 or more, systolic over 110. All right. Oh, and then permissive hypotension worsens up, and that's when do we use a permissive hypotension? I think we talked about the military medicine. Was that? Yeah, like a hemorrhagic shock type patient that we're worried about, losing any of those clots in, it may be appropriate. Good. So, it's important to remember that when they have a traumatic brain injury, it's still a trauma patient, and most commonly that hypotension is going to be from some sort of hemorrhagic bleeding somewhere. So we don't want to assume, well, maybe this is from this isolated head injury. We need to consider hypovolemic shock and treat that aggressively. Don't assume that it's a neurogenic shock from that blood pressure, because it's a lot less common. It is a trauma patient. If we've given fluids and blood, we move on to pressors at that point. And then simple maneuvers we can do, we can elevate the head of the bed to 30 degrees. It's going to be probably the first initial treatment we're going to do in anybody who has a suspected traumatic brain injury. It can decrease that mean pressure like 10 to 50 millimeters of mercury. So it can be extremely helpful in these patients. And then we want to keep them euglycemic, so any hyperglycemia can worsen their outcome. So if, when we're initially checking those labs, if they're a diabetic, which is very common, especially since the elderly have a lot of falls and we're treating them, we want to look at giving them insulin drips and keeping their glucose in the normal range, normal ER range. I know that's not the normal range, but in the ER, anything under 200, we're like, all right, they're cool. We don't really need to really anything under 300, but for TBIs, you know, we're going to keep it 100 to 180. I want to treat any fevers. We like to use seizure prophylaxis in these patients. What's the common seizure prophylaxis for these? Anybody know? Keppra, yeah, Keppra. However you pronounce the generic name, levetiracetam, levetiracetam. You might hear it a lot of different ways. And then we're going to run our normal trauma labs on all of these patients. And here are important signs we need to consider with our brain injury patients. So we're really looking for any signs that they have an increased intracranial pressure, because that needs to be managed more aggressively with the neurosurgeon. And you know, we have some tools where they can place some drains in there, or they might have to do some sort of burr hole to remove that, or craniectomy in these patients. So if they have, you know, if the patient's still mentating, they might complain of like a very severe worsening headache, maybe visual changes, numbness, any sort of focal weakness, nausea, vomiting, seizure. These all can be indicative of increased ICP, and we need to manage them a little bit more aggressively. All right, and then here are like signs of impending herniation. So once we start to see any of those like pupillary changes, so whether it's unilateral, bilateral, if they start to get that hemiparesis, any motor posturing, or they were initially had a normal neuroexam and now we are progressing to a focal neuroexam, we need to consider that they have some sort of herniation or increase in their cranial pressure. And then if we find these, you know, we can't get them immediately to the operating room, we need to measure their GCS usually every 5 minutes while they're in the trauma phase, so we can get them up to the operating room. All right, what else can we do for an increase in intracranial pressure? So we can use, you know, one of the things we use is an osmotic agent called mannitol. So this is something that decreases that ICP, improves cerebral blood flow. One of the issues with it, though, is it is a diuretic, so you run the risk of causing a hypotension with it. So there's been more and more evidence throughout the years that probably normal saline is a lot better for any sort of traumatic brain injury. And in these cases of increased ICP, we want to look at hypertonic saline is going to be what our mainstay is, but we can use them both. I mean, they're both still commonly used. Mannitol, I think, requires you to use a warmer. So it's a little bit easier for us to use hypertonic saline in the ER because we have it more readily available. But this is something that's still commonly used for acute herniation. Then here's our hypertonic saline. So preferred over mannitol. You know, especially if we're concerned for any sort of hypotension or we needed to fluid resuscitate them, you know, we like to use that hypertonic saline. Commonly, we have 3% in the ER. They have a lot of higher percentages, like 20 something. There's a bunch of different ones you can use. We typically use 3%. We start with like, you know, 200 milliliters. We can also give them, you know, in conjunction with mannitol and hypertonic saline. So they both are commonly used, and you should know them. So what's an abnormal ICP? Anything over 20 is what we consider abnormal or increased morbidity and mortality. ICP normally is probably like 5 to 15, but 20 is kind of our cutoff for when we think it's going to cause some sort of increase in their morbidity and mortality. And we need to make sure we're consulting neurosurgery early so we can get different types of fluid drains. You guys will talk about the different ones in surgery when she covers TBI as well. All right, so another consideration is going to be skull fractures. And really what we're looking at is where the location is and what sort of vasculature might be below. And then we also want to know whether it's like an open fracture, whether there's a, you know, it's depressed. If it involves a sinus, then we need to look at using some sort of antibiotic prophylaxis because we can get air in there. And we want to prevent any sort of secondary infection that can worsen their outcome. All right, and then We have our basilar skull fracture, CSF leaks. So these are going to be the ones that involve they can involve the petrous bone, temporal bone, auditory canals, your tympanic membrane. I'm sure we all remember the like raccoon eyes and battle signs and all of those other findings you might see on exam, but it can occur anywhere along the skull base, so we may not have any findings on exam, but it is something we need to consider. Any patient with findings, we want to avoid like a nasogastric tube through the nares, just because we don't want that to go into the brain. All right, here's our findings. So what we're worried about is some sort of CSF leak, and I have like, I don't know, it's kind of weird how many patients I've seen that say they have a CSF leak, that they have some sort of pink on a Kleenex, but yeah, I guess that's what you might see. You also see, the mastoid ecchymosis, periorbital ecchymosis. We want to check their TM, so we might see some blood behind there. And then if they're still mentating, they may complain of vertigo or hearing loss. You can see a 7th cranial nerve palsy as well. So because we have some sort of disruption in that, in the basilar area of the skull, we worry about some sort of risk for meningitis, so we want to make sure we got antibiotic prophylaxis if we do identify this on exam. All right, now we'll go into like our specific head injury syndrome, so traumatic subarachnoid hemorrhage. You got some sort of disruption of the parenchyma, the subarachnoid vessels, and you can cause it causes some sort of leak in there. This can also have blood in the CSF, so that's why if they're not within that 6-hour window when they present, and we still suspect subarachnoid, we may have to do a spinal tap on them. So it is common, especially in our moderate to severe TBI categories. And then there's what it might look like, that xanthochromia on exam, or on our once we drain it. So this might be what we see. There's your normal, it should be clear fluid. And then if we have that xanthochromia, it increases our risk for any sort of subarachnoid hemorrhage. So once again, if the scan's not within the first 6 hours, then we need to consider that if we don't see anything on their imaging. Then we have our epidural, so we have that space between the skull and dura mater, and then we have that some sort of disruption of that middle meningeal artery. That's like a common board question too. This one is subdurals, what causes those, and which ones can cross suture lines. But what's important for the history on these ones is this is somebody had significant head trauma. They had a lucid interval after or normally on the scene, so they were still mentating appropriately, or when they presented the ER, and then they have a decline. So that's common in our, I don't know about common, but it's common on a board question for our epidural hematomas. So this one, usually a little bit, this one's, or can be a lot worse than our subdural hematoma because this is arterial bleeding. So we can have, signs of that herniation, or it can lead to that herniation. That's why we want to recognize these early and get them some sort of neurosurgical intervention so they can evacuate that hematoma before it leads to herniation. And then there's a great CT of that, like convex, lens-shaped looking focal lesion. Next is our subdural hematoma. So this is going to be those carrying those bridging dural veins. It can be from like acceleration, deceleration, any sort of head trauma can cause this. It's doesn't form as rapidly as our epidural hematoma. It's very common to see it in elderly patients. We can even see chronic subdural hematomas as well. So the reason we see it in elderly and alcoholics, we have atrophy of the brain, so there's a lot more space in there, which is why we see these lesions more frequently in them. And then we have a ton of benign, small, falls in these patients. Like I said, it's probably the most common thing we see in the trauma room is an elderly patient who fell and hit their head. At least at AMC we do. At university, you see a lot more bad stuff. And not as many of the elderly. I don't know why they send them to AMC mostly, but we can all see it, our young pediatric population as well. And like I said, we can have a chronic subdurals, and then we can have like subacute and acute. And sometimes these patients will be asymptomatic, so we consider chronic, over 2 weeks. You might not have any symptoms initially. Sometimes we'll incidentally see these on a CT scan, which will be a patient that fell, and then we'll show some images, and it looks a little bit different on the images. And we'll be like, oh, it looks more chronic than acute. Or they might have an acute on chronic presentation as well. So you never know how these present. My dad actually hit his head on a cabinet, and like 4 days later, he crashed his car. And then he didn't crash, he didn't get hurt or anything. He just drove over a curb and popped a tire. And he was not mentating well, and then went to the hospital, and they were like, oh, when did this happen? And I think it actually happened a week or two before that. So he had a chronic subdural that eventually became symptomatic. And here's kind of our different findings on here. So you'll have like a hyperdense finding with that moon-shaped kind of finding, and then you can have isodense or not as dense. And then you'll have like your dark finding on there, or hypodense. And that's from the iron in the blood's metabolized. So here's some images. This is an acute. So you got that hyper dense area. And then as you move into your chronic, you'll see it becomes a darker area on there, or a hypodense area. So these are the common findings. The other one's an MRI on there, which not as commonly performed in the ER. Some facilities may have the capability. And then these, definitive treatment kind of depends on what sort of findings the patient has, location. A lot of the patients we may not do anything for, especially those elderly with the chronic findings. Either way, we're going to consult neurosurgery for these patients, and they're going to come up with our disposition for us. And then here's like a comparison of those intracranial injuries that we see. So, like I said, big thing for the epidural, they may have that lucid interval with it prior to deterioration, and it involves the middle meningeal artery. Subdural, we have that crescent shaped. See it a lot in those elderly patients. Can be chronic. Subarachnoid, that's going to be any age group, but usually significant trauma, and we'll have those findings. But as you can see, the two that are easy to differentiate, epidural, subdural, so commonly asked on board questions. All right. Next we have our diffuse axonal injury. So some sort of, axonal fibers in our brain gets disrupted, usually from some sort of deceleration injury, and it causes shearing forces. You see a lot after blunt trauma. You can see it in infants with the shaken baby syndrome. And then this one is a common finding on CT. I think it's this most common. I don't know. I meant to look that up. You guys use open evidence yet? If you don't, it is the best. Before you go to phase 2, make sure you guys download it and start using it. It's like up to date on steroids, but it's free. It's amazing. All right. So the unfortunate issue with these is they're often like irreversible neurologic deficits, but you'll have that injury on the gray and white matter, and we'll look at a CT here, and it just kind of looks like everything kind of blurs together on those images. Once again, we do the same thing in the emergent setting, is try to prevent any of those secondary injuries, and then consult our neurosurgeons. So there's, how it looks on CT. So not as, it's kind of difficult, right? It doesn't look super abnormal, but it looks abnormal. I mean, this one, you got all those skull fractures, so hopefully that's easily noticeable on there. But sometimes the diffuse axonal injury may not have as impressive findings on CT as the other lesions. So what do we do for, our most common presentation, which was, 80% is going to be our mild TBI. So And I'm sure people in here have had a traumatic brain injury before. So if if we have normal imaging, their GCS score was typically that like 14 to 15, no neurologic findings. A lot of times we can discharge these patients home. We just need to make sure we give them good concussion discharge instructions, make sure we explain return to play criteria for their athletes or they're doing any sort of contact sports. It's also important to discuss with them they can be symptomatic sometimes for months afterwards or longer from post-concussive syndrome. And then it's also something to consider is, how frequent they're getting those traumatic brain injuries and CTE for, our people that are at risk for it, like, contact sports players, football and soccer, I think are the two most common that we usually think about with it. And it's important to remember that the guidelines are, I think there's a new study on concussion and, what the return to play criteria, whether they get, how long do we need to do brain rest? You see that studied a lot more frequently. And it used to be, we give them brain rest for, I don't know, like weeks it seemed like. And now we're down to like a day or two. So it's important just to look at the latest research because it's something we still don't understand very well for our like mild TBIs and concussions and what good criteria are for returning them to activity. I mean, it used to be do nothing, and now it's like, well, they can start being a little bit more active a couple days later. So it's important to look it up. Anybody on anticoagulation is something we need to think about when we're treating these patients, and especially if we're looking at like discharging these patients. So these are patients we may want to consider repeat CT imaging in 6 hours if they're on anticoagulants and we're going to discharge them. And we had normal findings initially because they can have a delayed hemorrhage. For most of the ER or ED treatment, we're usually going to admit them to the hospital and we'll further evaluate them. We don't like to keep anybody in the ER for more than 6 hours as a no-go. All right. So like I said, we can discharge and make sure we have good follow-up for these patients. Usually it says GCS 13. Sometimes. Or less than 13. Sometimes 13 we're going to still admit to the hospital, but a general rule, anybody 13 or less, we typically admit them to the hospital for serial evaluation and observation. All right, we got some check on learnings here. Good. EMS brought a 19-year-old male to the ED after an altercation at a bar. He has shallow respiration, moaning, opens his eyes, being stimuli. He has abnormal flexion towards the body, seems to lose among his mastoids under his eyes, which is the most appropriate next step to managing this patient. What do we think? Who says we should perform a surgical crime? Nobody? All right, this one's going to be easy, so intubate. That's like the answer for most of the trauma blocks. Like, do they have an airway? If not, if anybody was like a paramedic or anything before, had to take the, National Registry. That's like half the questions. It's like, did we open the airway yet? Oh, there we go, open the airway. Seems to be the right answer most of the time. All right, so we got 24-year-old male. Have a head trauma after motorcycle accident, demonstrates papilledema on physical exam. I don't know how they saw that, but awesome. As well as optic nerve sheath diameter 8 millimeters. So that's something we can do is bedside ultrasound. Okay, we measured that. Good. You guys will do that on each other here in our next block. It'll be fun. All right, he has been resuscitated, 2 units of blood, remains hypotensive, current vital signs 8/60, heart rate 124, rest was 18, 98% on the ventilator. Responding interventions, next best step, managing this patient. What's that?
Delta?
Yeah, this one's tricky, right? You're like, let's give him some blood. I know it's hard when blood's an option in trauma. You're like, you probably need blood there. So, yeah, he's already been resuscitated with 2 units of blood. So, I mean, likely we can continue administration of blood, yeah, but what we need to look at now is some sort of herniation syndrome. So he's got that signs of elevated intracranial pressure, so he's got that papilledema, nerve sheath diameters increased. We've already got blood going and we're not seeing improvement. So we'll give, at this point we want to administer hypertonic saline. They'll probably still continue to get blood. And we will elevate that bed.
So it was hypertonic saline?
Yeah.
Okay.
Administer hypertonic saline.
Okay.
Yep, you got signs of herniation or increased intracranial pressure, not herniation, but so yeah, we want to get some sort of hypertonic saline on board. All right, let's see what type of herniation syndrome this is. 34-year-old male presents to the ED following a severe head injury during a motor vehicle accident. Exhibits right side pupillary dilation, ptosis, altered level of consciousness, left side motor paralysis. Which of the brain herniation best describes these symptoms?
I mean, Dad, Charlie out.
What are we thinking?
C?
Not C.
Okay.
Yes. Common's been common. Go with. I like it. You went with self-fallacy. Most common. That's good. Yep. If I would take a test and I didn't know, I would guess that. This one's uncle herniation because this one's like the most easily identifiable, which is why it's always asked. So it is uncle herniation. So you have, that right-sided pupillary dilation on whatever side that lesion is, and then you have that contralateral motor paralysis. All right, what questions do you guys have? You guys ever ask questions in other classes, or just? Okay, good. All right, cool. It's not me.
No.
Perfect. Be back at 10:30, and we're going to continue on in the neck trauma. Check on learning. 71-year-old female suffered a fall yesterday, brought to ED by her daughter, not been acting like herself, confused, memory difficulty. On exam, she's in a 10, mild weakness in the upper and lower extremity on the right. What do we see on this CT? Yeah, acute subdural hematoma. Which of the following is an indication for an ED thoracotomy? What are we thinking? C. Yeah, C, right? So, strongest recommendation is for performing ED thoracotomy. This is going to be any sort of penetrating chest trauma with witness signs of life during transport. Good. Good. All right. Which of the following treatments is never recommended during managing a patient with traumatic brain injury unless they are acutely herniated? Hyperventilation. Yes. Good. So, A is going to be, anybody we suspect increased ICP. Everybody should get the head of the bed elevated. Insulin drip if they're hypoglycemic, and then most get Keppra as well. Everything else is pretty much indicated. All right, what is our recommendation regarding the administration of TXA for acute trauma? What do we think? D? Yes, D. So 2 grams in the first 3 hours. Perfect. Well, let's talk about some spine trauma today. All right. So we can have, our vertebral spinal column injury. We can have injury to the spinal cord. We can have both. Our concern, our biggest concerns are going to be whether they're stable versus unstable lesions here or pathology, but pretty common injury that we see. You know, it affects males more because we're stupid and like to do dangerous things. But the leading causes are going to be like our MVC, falls, and then violence. Here's for a quick refresher, we got 33 vertebrae. So we got 7 cervical, 12 thoracic, 5 lumbar, 5 sacral, and then 4 coccygeal. And the last 2 are usually fused. But the most commonly injured is going to be our cervical spine, which makes sense because we don't have the protection of, you know, our thoracic cavity, our ribs, or our abdomen to help protect it a little bit. And then after the C-spine, we have thoracolumbar transition zone. Is going to be our next most injured region in these patients. It's important to like conceptually understand we have ligaments that help maintain alignment of the spine. So any sort of disruption in those ligaments is where we run the risk of instability, and we'll talk about some of the criteria we use for it. All right. So our thoracic spine is going to be, you know, less injured because we have the protection from our articulation with the rib cages, or with our ribs. So any sort of injury to these, we need to look at concomitant injuries somewhere else in these patients just because of the amount of force that's required. So we want to look for any sort of, you know, intra-abdominal injuries if we have, you know, a T-spine fracture or any injury in that area. And then we want to look for like those hollow viscous injuries and make sure we're, you know, properly evaluating them for anything else. All right, and then we have that thoracolumbar junction, which is that second most commonly injured area. And it's that transition from our thoracic spine and the protection from the ribs into our lumbar spine. And then it's also the transition point for the end of the spinal cord, which, you know, all the nerve roots kind of come together for the cauda, what we call the cauda equina. So that's always a consideration we need to think about in these patients. Yeah, and like I said, most don't have neurologic deficits, so that's why it can be difficult, and we have to kind of use our history and mechanism to help us identify these. And then we have our more mobile regions like L3 to L5. So we don't commonly see isolated injuries to this area or neurologic findings. And then as the spinal canal ends and the width of the spinal canal is a little bit narrower down there after the cord ends, we can have issues with our cauda equina, and then our sacrum and coccyx are the lower portion. And really, the sacrum can have concerning findings of fractured coccyx, not so much. And the coccyx articulates with the sacrum, so in this area, usually it's like a cauda equina syndrome type picture if we have any injuries there. So they may have that bowel and bladder dysfunction, which most commonly results in urinary retention, not so much as like they pee or poop themselves. All right, and here are the lines we're looking for when we're evaluating an image. We don't normally get a plain film of the cervical spine or any of the spine. Most everything we do is going to be CT, but here's our lines that we're looking at, and these kind of correlate with where those ligaments are and what sort of stability we have in the spine. So it's important we want to assess that entire area, and then we have straight lines. All of our vertebral bodies are lined up appropriately. We don't see any like anterior or posterior translation of those. And they correlate with those, what ligaments we have there, which we'll talk about. We do like to look at the prevertebral thickness, so we say like 7 at 2, 2 at 7. That should be 2 millimeters, not centimeters. Or no, that should be centimeters, sorry. It's, yeah, 7 millimeters at 2 and then 20 at 7. But we try to make it sound right. I think it could be up to like 22, but we won't go into it. Here's what's important. So these are our different ligaments we have. So we have, we like to break this up into the Dennis column system. And so we look at like our anterior, middle, and posterior elements. And they each have corresponding ligaments in there that if we have a disruption to any of those 2 columns, we worry about the stability in that area and worse outcomes in spinal cord injury. So any 2 columns are involved, and we consider it an unstable fracture. And we'll talk about the fractures because we classify some as stable versus unstable, but if we see anything, you know, it may be considered a stable fracture, but if we see a disruption in these, we would consider it unstable at that point, which I know probably sounds confusing. So a lot of times with like MVCs, we'll have polytrauma, so sometimes these can go unnoticed, or they might have more significant injuries that we're going to have to evaluate for first. Unfortunately, for our spinal ligaments, MRIs are going to be the best test, which we don't typically have emergent MRIs in the trauma room or emergency department. So we want to make sure we're evaluated on CT and then determining whether it's stable or unstable. If there's any question, we consider it unstable. And we consult the spine surgeon. Depending on where you're at, like you'll have either ortho spine or you'll have neurosurgery will evaluate these. Advancedly, like they rotate it all the time, so it's very complicated to figure out who's actually on call that day of the week. And then here's our unstable fracture. So we have our Jefferson. What type of fracture we see on the right?
EMED?
What's that?
Is that the hangman?
Yeah, it's going to be hangman fracture. So that one's going to, you know, this one is involving that C2. And then you have that like anterior translation, both the one vertebral body and then posterior or posterior translation of the other. So that's definitely an unstable fracture. But the three that we're going to discuss are going to be like your Jefferson. So that's commonly like somebody dives, lands on their head, or they get hit with something, an axial load on the top of their head. We worry about that C1 ring blowout. And then the hangman's is, you know, kind of self-explanatory. It can be from a hanging injury, or it can be from a hyperextension injury. So motor vehicle crashes can also cause this, and it's something we need to consider. And then we can have our mixed stable and unstable. And really those are ones involving either the one or both of the facets, or it can be an odontoid fracture. So certain odontoid fractures are considered unstable. And it just depends on what it involves, whether it's, you know, the tip of the dens versus other areas of the dens. All right, here's some of our stable injuries. So burst fractures, and we call them stable, but if they only involve like one of the ligaments, then it would be stable. So sometimes they can be mixed as well, but typically we consider them stable fractures. We got the clay shoveler, so that's going to be like your spinous process, usually in that like C7 area. And then we have our chance fractures, which is going to be usually involving somewhere on that thoracic spine. And these are ones related to that lap belt. As you can see in the picture, the guy kind of folds in on himself, wasn't wearing the belt appropriately. And these ones are ones we have to worry about concomitant injuries, like hollow viscous injuries, abdominal injuries, things like that with those types of fractures. So we may consider them unstable for those. And they can be tricky because a chance fracture can look like a burst fracture, but we won't get too in-depth on that. All right. So we have our initial trauma or insult to that spine, usually from some sort of mechanical forces, whatever the mechanism was that caused it. Then we also get a secondary injury, so we get, you know, vascular and chemical processes that can cause like inflammation, edema in that spine. And then it can present on exam like they have a complete disruption or a complete lesion on there, so we may not have any, reflexes or any sort of motor function below that level. So it can be hard to differentiate whether it's a complete lesion versus incomplete on exam, just because of that secondary damage you can have. So we classify these whether we think they're a complete lesion versus incomplete, and this kind of helps guide our prognosis for these patients and what we think their functional recovery is going to be. So complete is absence of sensory motor below whatever level the injury is, and then incomplete, they retain some sort of like sensory motor function below that or both. If it's complete, there's going to be a very low chance of functional motor recovery afterwards, which is why we like to establish the prognosis beforehand. But once again, because of that secondary injury, it can be very difficult in the emergent setting to determine that until all of that inflammation or that those spinal injuries can help resolve, and then we can get a better idea whether they're going to whether it's complete versus incomplete. So it's something that's not something that's difficult to determine in ER. And then so we have our descending and ascending tracks. We won't get too crazy into it. We got our cortical spinal, which is like our upper and lower motor neurons. So you can have like contralateral, like distal limb issues in your hands or your fine motor movement, spinal thalamics like pain, temp, touch, pressure. And then the dorsal is going to be like our fine discrimination, proprioception, and vibration. And then our pre-hospital treatment. So it's important that we recognize who's at highest risk for this. And then they'll on the scene or pre-hospital provide appropriate immobilization, which is usually C-collar and the spine board are still most commonly used. There's questionable data on whether spine boards actually help. Most of the data says they do more harm than good. So we try to remove those spine boards once they actually make it to the trauma room. And then it's important that EMS triages at the right facility that has a neurosurgeon or spine surgeon capability. All right. So it says we still recommend use in the pre-hospital setting. Right now we try to remove the spine board when they come in. We'll talk about criteria we can use to help remove those interventions, which we use like our nexus criteria, and we also have like some C-spine imaging criteria we can use as well. But big things, what was the history, what was the mechanism of injury, and then do they have any midline pain or any sort of neurologic deficits? If they have any like dyspnea, palpitations, any sort of abdominal breathing, we consider like a higher C-spine lesion or really anything above C5. We worry about respiratory or losing their airway, so they can tire out if it's a higher lesion because it affects those nerves in there.
Let me interrupt, sir, but y'all have an electrical problem at what facilities? Y'all need to get that fixed now?
Just like all trauma, we do our initial primary survey, so we're going to airway, breathing, circulation. Like I said, higher level spinal injury, we worry about some sort of airway compromise because it can affect that phrenic nerve, diaphragm function. So some recommend securing the airway anybody with an injury above C5 if they're not already intubated. And then you'll notice that initially they can compensate, so they can have abdominal breathing, they can use intercostal muscles, but they eventually tire out, which is why we need to identify this quickly and decide whether we need to secure their airway or intubate them. And when we intubate anybody with a C-collar, we need to maintain manual inline stabilization. So that's when you'll have somebody holding manual stabilization while you intubate in case you have to manipulate or move the patient at all. And then hypotension and spinal cord injuries, it could be due to neurogenic shock, but kind of like I talked about with TBI, we're going to assume in a trauma patient that it's going to be the hypotension is typically from some sort of hypovolemic shock, and so we need to get blood or crystalloids on board before we relate that to some sort of neurogenic shock. But neurogenic shock may have that like hypotension, and then they could have bradycardia, which normally we'd expect to tachycardia with hypovolemic shock. All right, so once we stabilize them, we've completed our primary survey, and we need to then look at doing some sort of detailed neurologic exam to determine what level or of dysfunction these patients are having. Typically, we'll probably get a CT first, but sometimes we won't, and we'll have to assess that prior to. So it's usually like more of a basic neurologic exam. We want to look for that saddle anesthesia or sensory deficits. DTRs are something we need to assess on these patients. And then, if they have sacral sparing, that usually indicates an incomplete spinal cord lesion. Any priapism is going to be a complete spinal cord injury. So that's something to note on exam if you find it. And then we'll talk about cauda-equina syndrome, which is something we always worry about, especially in trauma and anybody with, like, you know, their back pain. We always talk about, like, they pee or poop themselves and that, you know, they have the saddle anesthesia, but sometimes those aren't as commonly seen with it. Urinary retention is going to be the most common finding that we're going to have. Most of the time, motor and sensory are going to be normal, so that's kind of hard to tell. I think like the ankle reflex is probably the most associated on physical exam findings with it according to the latest data. But most patients are just going to have like a sciatica type picture. They're going to have that ridiculous symptoms moving down their legs. And these patients are one of the few times that we're going to get an MRI in the emergency department if we suspect cauda-equina syndrome. And then neurogenic shock, you know, it falls under the distributive shock category. You know, less than 20% of the patients, which is why we like to assume that it's some sort of hypovolemic shock causing that hypotension in the patient. But you get that loss of peripheral innervation or sympathetic innervation. You get vasodilation, that blood kind of pools into the distal circulation and causes the hypotension. If, you know, depending on where that lesion is, you can lose like cardiac innervation, or you get unopposed vagal parasympathetic innervation. So that's what results in bradycardia or the absence of reflex tachycardia, which is what your body normally should do. These ones are going to have warm, you know, they'll warm, dilated skin findings on exam, and then there'll be hypotension with the relative bradycardia. But like I said, it's one of exclusion. Assume hypotension is in the trauma patient is hypovolemia. And spinal shock isn't neurogenic shock. Spinal shock's really when we have all of those inflammatory secondary injuries, and it causes that temporary loss of those reflexes, which makes it difficult to decide whether it's complete versus incomplete lesion. Typically they're like present with a flaccidity, loss of reflexes, they don't have any voluntary movement. And like I said, it can already mimic, you know, complete injury, so that's why we can't fully evaluate whether it's complete or incomplete until further along in their care after they're hospitalized. The first things that return are going to be like that bulbocavernous reflex. Everybody remember what that is? It's like my favorite reflex. Yeah. All right. So what do we do for imaging? We, you know, nowadays most imaging will be CT scanning is going to be what we prefer. And then we do have some rules we can use on whether we think they need C-spine imaging or whether we can clear them from their cervical collar while they're in the ED. So we don't have to scan everybody. If they have the right mechanism, then we do. But we have our nexus criteria. Has everybody heard of the nexus criteria? So this is going to be, you know, a decision rule on whether we need to image that cervical spine with a CT scan. So if, I think I have some, yeah, here we go. So it's a clinical decision rule. So if they meet all these criteria, then it's a very low likelihood that they have a cervical spine injury. And we can clear them or we can avoid a CT scan in these patients. So if they don't have any midline cervical tenderness, so that's like bony spine tenderness, they're not altered in any way, so they have normal LOC, they're alert, they have no evidence of intoxication, and then if they have absence focal neurodeficits, and then they don't have a painful distracting injury like a femur fracture or some sort of intra-abdominal injury, then we can clear their, we can avoid a CT scan in these patients. You know, some use the acronym like SPINE, some use NSAID, which is there's a neurodeficit, spinal tenderness, palpation, altered mental status, intoxication or distracting injury, we don't. Then we need to make sure we image them. All right. And this was something we did before CT scanning to evaluate these patients because plain films weren't as, you know, they're not as accurate or sensitive and specific. And then we were over imaging patients, so this helped us kind of determine whether we think they needed imaging or not. And it is, you know, widely validated, good sensitivity, and if the patient's low risk, then we can decide whether we need to avoid imaging or perform imaging on these patients. Plain films, once again, not commonly done in the emergent setting to rule out any sort of fracture. We do our CT imaging. Now, with that said, if we find any injuries, especially for surgical planning and for monitoring their progress throughout the stay instead of repeat CT, and ortho will want plain films normally in them as well. So, we may get some plain films just to assess for healing and everything, but typically CT scan, any findings, we may get a plain film for ortho if they request it. I mean, the nice thing with plain films, you can do them at the bedside, a small amount of radiation, they're cheap, but just poor imaging, especially body habitus, can affect this. Any elderly, like any really muscular patients, we won't be able to evaluate the entire C-spine, which is why we don't like to use plain films. And there it is, CT is going to be our test of choice for this. We can evaluate that cervicothoracic junction really well with it. And even if we get a plain film, we see something, we're still going to get a CT scan, and typically vice versa. All right, so if there's any pure ligamentous injury, this is going to be something that we'll mostly see with our exam findings, and we may have normal imaging is something we still need to consider. So if they have persistent neck pain, they have midline tenderness, but we have normal imaging, and we have any sort of focal neurologic findings, we need to consider a ligamentous injury, and that would be more of an MRI that we need at that point, which is sometimes difficult to get an emergent MRI, so we may have to consult ortho or a spine doctor immediately for this. And like I said, MRI is going to be our best test for any ligamentous injury. If we're unable to get that, we're typically not going to discharge them, especially if we have a spine surgeon, we're going to consult them. But some cases, if they are reliable, have good follow-up, could be managed as an outpatient with an outpatient MRI. We don't have any good rules for thoracic and lumbar imaging. Really, we're going to get that CT of the brain, neck, chest, abdomen, and pelvis in anybody with the right mechanism of injury. If we have any findings on exam and we weren't imaging for that, we need to consider CT at that point, especially for neurologic deficits. Any like bony spinal tenderness, we need to consider thoracic and lumbar imaging for. If we find anything on there, we need to image the entire spine. So CT and L spine need to be completed. If we find anything even on the cervical spine, especially on the thoracic spine, we would we need to perform imaging on those patients of the entire spine. And then what's our goals of treatment? Pretty much the same for everything else, right? We just want to prevent secondary injury. So we want to make sure we limit the mobility of that spine. And then we want to get a good neuro exam and decide whether this is somebody that needs to go to the neurosurgeon or spine doctor so they can get surgery to stabilize it, or whether we need to monitor them inpatient. Most patients with a fracture we're likely going to admit, but some of them may not need to be admitted if we can. If they have reliable follow-up, we can get them in the right or appropriate brace, which is like our, we have different braces we can use for them, like TLSO braces. But like compression fractures are something we commonly see, especially in the elderly. So any loss of vertebral height over 50%, or if the angle between the damaged vertebra and the rest of the column is over 30%, 25-30%, then we generally consider those unstable and we need to consult ortho, or we have to admit them to the hospital for those, and they'll get they'll put them in a brace and then kind of monitor their progress and decide whether they need to do surgery or not. And like we said earlier, that chance fracture or anything in that thoracic spine, it requires a significant amount of force to fracture that, so we need to look for other injuries in these patients. This is what you normally see on your imaging. So you'll have a transverse fracture, and then you have some sort of increased height in the posterior vertebral body, and then a fracture of that wall, and then posterior opening of the disc. So these are significant findings if you see it, and make sure we rule out any other injuries with those. Pathologic fractures, that's something we want to consider, especially in the elderly patients, anybody with cancer, Any like osteoporotic process, we want to consider pathologic fractures. And once again, you find something on plain films, you want to get a CT scan of them. And then the sacrum and coccyx. So, you know, not as commonly seen. Usually if we do see this, they have significant like pelvic injuries as well. So that's usually going to be the more aggressive portion of the management. You could have a fracture of the sacrum that affects the cauda equina, so something we need to consider. And then those ones, since it involves cauda equina, can have that bowel bladder dysfunction. And then our coccyx fractures, which are usually relatively benign. They're, you know, a super pain in the butt according to the patients, but we don't do a lot of coccyx fractures. If it's, you know, isolated, you know, we don't need to consult anybody for these. Usually it's a fall on the butt. They either slipped or they fell somehow. They landed directly on their coccyx. And then they'll complain of like worse symptoms while they're sitting or straining. These patients we can manage with just analgesics and a donut pillow. And then the question is, should we give steroids for spinal cord injuries? This is something you want to consult your neurosurgeon before you're given steroids. So the issue is if they have some sort of brain injury, we can worsen that with corticosteroids, so they usually are avoided. But it'll be up to your spine doctor on whether they want to give them steroids. And then neurogenic shock, we don't need blood for it. This is going to be like crystalloids are going to be our treatment of choice or our IV fluid of choice for these patients. If, you know, we're not able to control it, then we can add on a pressor for these patients. And we usually keep their MAP and their blood pressure within just a normal range. It's not like over 110 like for head injuries. All right, let's do another check on learning. 26-year-old patient who was brought into the emergency department after snowmobile accident has already been evaluated, waiting for orders to be admitted. He does not have feeling below his mid-epigastric area and cannot move his legs. What physical exam finding would denote a complete cord injury? Yeah, priapism. Good. All right. Which portion of the spine is most commonly injured?
Transitions.
Cervical. Cervical spine, so that's E. And then 77-year-old male is brought in by EMS to a rural AD following a motor vehicle accident in which the two-door car he was riding in was struck from behind by a pickup truck moving at a higher speed based on his plain film below, and the expected mechanism of extreme hyperextension with fracture is most likely. Yeah, our hangman fracture, right? So not as impressive as that earlier image we had, but you can kind of see the fracture going through the vertebral body in the posterior portion. All right, what questions y'all got? All right, I'll hang around in case anybody has any questions. Who's supposed to teach next?